Hi, my name's Nick Holding. I'm an improvement manager with the Emergency Care Improvement Support Team. Welcome to the latest podcast in our series. These podcasts are an opportunity for us to meet and chat with some really interesting people from across the NHS and social care and share with you guys what they're up to. We've got over 50 episodes in our series so far, which you can find at the link below in the text. Today, I'm delighted to be joined by Dr. Rachael Grimaldi and Dr. Gordon Caldwell to talk more about communicating with inpatients whilst they're in hospital. Rachael, Gordon, would you like to introduce yourselves?
Yeah, thank you so much, Nick, for having us. I really appreciate it. I'm Rachael Grimaldi. I'm an anaesthetist. Just started my final year of training at Great Ormond Street Hospital, and also the Associate Medical Director for the Brighton Marathon, and run the research team there as well, and co-founded Card Medic, which is a digital communication app, in 2020.
Thank you, Rachael and Nick. I'm Gordon Caldwell. I'm a consultant physician. I work in the Lawn and Islands Hospital in Oban. I moved there about 4 years ago now from working in Worthing. Back then, I was the Director of Medical Education, and I can remember Rachael being one of our foundation year doctors in Worthing Hospital and beating me at a competition on quality improvement in our postgraduate centre. Thank you.
Brilliant. Well done, Rachael. I just want to start this podcast with a story, a short story, if I may. I was talking to a nurse last week. She'd been on a night shift a few days earlier, and she described this scenario with a patient. It was about 6 o'clock in the morning. That had a really busy night, quite a heavy night, lots of coming and goings of patients. And she just went to this patient and just inquired, had he been able to get any sleep? How was he feeling? How was he getting on? And the patient was staring at this nurse. And the nurse was wondering what was wrong, what the problem was. All of a sudden he said, "In the 4 days since I've been here, you're the first person that's asked me how I am." He said, "Lots of people have come and gone. Lots of people have asked me questions and done stuff to me, but nobody's actually stopped and asked me how I am." This got me thinking about something you've talked about before, Gordon. You talk about the practice of medicine as a human relationship. And I think you talked about this on a previous talk that you've done for us. You talk about how we should know the person before we make them a patient, how we get to know them. Can you tell us a bit more about that?
Yes, I think I've always thought that the practice of medicine, certainly within a professional relationship, and I think it is actually a professional relationship. And what I'm trying to do when I'm practicing medicine is to know the person, to know their personal context, not just them as an individual, but as a person and a personality. So you can then put the disease and the illness into the context of their own lives. So we're not trying to do the same thing to every patient with the same condition. We're trying to know who the person is, understand the impact that has on their life, and to then negotiate with the patient the appropriate treatment for them. So I usually approach that by asking some simple questions. What age are you now? Because that gets the person talking, because they usually know how old they are. What is or was their occupation? And certainly since I moved up to Oban, I realized that you don't ask anybody what was their occupation. You ask them if they're still working. So I had patients who are well into their 80s who are still keeping cattle and sheep up here, or running a bed and breakfast. So lots of people are still working. And then to ask them what their interests are and what things they enjoy these days. And that's a very pertinent question, because some people are so ground down by their illness and their circumstances, they're actually not enjoying anything. And that, for me, creates some sort of connection with the patient, so that I can remember actually often their whole social and clinical context from what I'd call a memory hook. So one of my patients up here started drinking whiskey at the age of 7, and that's because the politician's ship sank off his island carrying all the whiskey for whiskey galore, and his mother sent him off at the age of 7 to go and have a couple of tots of whiskey. So then you can remember from that all about the patient, but it creates a connection. So like in your account there, when you go to the person, you're interested in them as a person, not just as the progression of their disease. And that's been very important to me all the way through my clinical career. Thank you.
So in terms of that communication, because obviously there's going to be all sorts of barriers to those those communications with patients, whether it's where you are currently or whether it was previously when you're in Worthing or previous to that. What's the kind of problems you've experienced over the years with regard to those communication barriers, and what are the sort of techniques you've used to overcome those?
Well, looking back over my career in medicine, the commonest problem is deafness. And I'm sure that Rachel would agree that a lot of doctors seem very uninterested in the ways that will fail to document that somebody's deaf or blind or deaf and blind, or maybe simply can't read is another problem. So that we can approach a patient and not know they're deaf. But even knowing they're deaf, the communication can often be very difficult, because often we then resort to shouting, and we wonder why the battery for the hearing aid's been lost, or the hearing aid is lost altogether, or is making that huge whistling noise. Because if a person's deaf, then they obviously have difficulty understanding. We don't have the same fluency of speech. And if we resort to writing things down, you've got doctors' illegible handwriting, and it takes an awfully long time. So deafness is by far the commonest problem. Visual impairment as well makes it difficult for the patient to understand our body language if they've got severe visual impairment. Then if we're trying to write something down for them to read, of course, if they're visually impaired, that also causes a barrier. So these very obvious things are very common. There's a more specialist area, people with problems with their speech, whether it's dysphasia, so they have difficulty understanding or finding the words to speak, and that's a specialist area where we probably need a speech therapist to help us with that. Dysarthria, where there's actually difficulty, may sound drunk or just difficult staccato speech. And patients with Parkinson's disease, I think, are very difficult to communicate with because they've lost their facial expression, have very quiet voice and a lot of noise around about. So specialist input there. Some people with learning disability also have great difficulty with communication. The area that I suppose people think most commonly would be people who don't speak English as their first language. I haven't worked in many areas where that's the case, but I have worked with professional translators and lay translators, and the best of them are superb because they seem to anticipate and understand what we're asking and what we're talking about. But sometimes it can lapse, I'm sure, into a lot of miscommunication because I'll ask a long question which is translated as 2 words, and then there's an answer that goes on for 5 minutes, and then the answer comes back no. So I think there's a lot of problems with people who don't speak English and the use of translators. And then when the pandemic came along, we had a new problem in that there was so little PPE to start with, and then patients were in cubicles that we were having to learn how to communicate through a wall or through a window, or with all the PPE on, of course, then very difficult to speak and to hear. So that was a new challenge. My solution on that was very simple, low-tech solution. I bought some A4 whiteboards, and we had one outside the cubicle and one inside the cubicle, and you could do very simple messaging to the patient, what do they want for lunch and that sort of things, and display the back through and such like, or the person inside could ask for extra equipment and so on. So those are my reflections over my career about communication. And then I heard from Rachel about her CardMedic as a novel solution to this problem of communicating either in PPE or through a window or such like. And I think it's probably got lots of applications outside of the pandemic as well. But I'll hand over back to you, Nick, and then over to Rachel. Thank you.
Yeah, I think that point about the pandemic has obviously exacerbated any existing communication problems by these additional barriers. So I know, Rachel, this is something that picked up on early in the pandemic. If you just tell us a bit of background to where that came from, what your thoughts were around that, and then we can talk a bit more about CardMedic.
Yeah, absolutely. Thank you so much. I think Dr. Caldwell, I can't really call you Gordon because you're still my first boss, so I just can't switch my headspace. So yes, and I remember your ward round so clearly, Dr. Caldwell, with always starting with who is the patient as a person. So just a reflection on what you were just talking about framing the whole patient, not just their disease process or what brought them into hospital, but who are they? Let's know more about them. And that helps you with that memory hook. So that's definitely helped me kind of in the way I've practiced medicine going forwards. But yes, about the communication, I think the scene's been set really nicely there about there are so many long-standing barriers to good communication in healthcare, and good communication is obviously key to patients being engaged in shared decision making and understanding what's happening to them. Like you mentioned, Nick, in that really sad story about that patient, that everything's being done to him, but no one actually asked him how he was. And so through my clinical practice over the last 12 years, I've had similar kind of experiences, patients with hearing impairment. We often think if we write something down, they'll understand it. But if their first language is British Sign Language, then English might be their second or third language. And we write something down, they might not be able to read it properly. And there's a whole host of communication errors there as well. So of course, and language barriers being a big one. So with CardMedic, I was on maternity leave in March 2020, visiting family abroad. And because of COVID, our flights were cancelled and I couldn't get home to help. I tried working in I was in the US. I wanted to help out in local hospitals, but of course, there's all sorts of kind of legal issues. You can't do that. So I was reading the news and I read about a patient who'd been to intensive care with COVID and was terrified because he couldn't understand healthcare staff through PPE, which is, exactly what you were talking about, that kind of acute barrier to good communication in healthcare. And it was a global crisis. So I thought, well, people must be writing notes on paper, or as Dr. Caldwell says, writing notes on a whiteboard. And I spoke to friends on the front line and they said, that's what we're doing, or we're shouting at patients, or it's a real challenge. So I thought, well, just really simply, if I made those notes that people were trying to write digital and created an A to Z library of these notes, and they're essentially pre-written scripts, if you like, because you do find yourself saying similar things when you're taking a history or explaining something to someone or asking them a series of questions. And we are getting your FAQs are going online. I think they're meant to go online today, Dr. Caldwell, so they will be there. I promise. They've been waiting to be published for a few days. So yes, we often find ourselves saying the same thing or asking the same kind of questions to patients. So I created this library of pre-written scripts, if you like, and my husband, whose background's not medicine, it's sort of e-commerce and websites, built the website, and then we launched within 72 hours. And then 24 hours later, I was encouraged to join Twitter, which I did. And actually, Dr. Caldwell, you were sort of my very early adopter, along with Rob Galloway. The two of you were absolutely brilliant. Honestly, it's down to you both for just tweeting and tagging and retweeting, and you posted videos and screenshots of things and actually just sharing it. Those first 3 weeks, we had 8,000 users in 50 countries. It just sort of spread. And then we had some media coverage, and the feedback we had was that there are so many long-standing barriers, and could CardMedic be around to stay? And then that's what I've spent the last nearly 2 years now working on, is building out the platform. So it's essentially an app that's available as a website or a mobile app, that this A to Z library of content can be presented to the patient in different languages, in sign language videos, in easy read, and we're building in pictures into the library, and then read aloud as well. For that same reason, patients might not be able to read, they might be visually impaired, they might be too unwell to read, so they can listen to the information as well. And then we have an integrated chat tool to allow for two-way conversations as well. And we have lots in the roadmap, and our kind of next biggest piece of work is to be able to integrate into electronic patient records as well. And so over the last nearly 2 years, we've had 55,000 users in 120 countries and 22,000 app downloads. And we've had some funding, been some accelerator programs, won some awards, currently working with Mass Challenge, which is a US accelerator, working with Brigham and Women's Hospital and City of Boston, which is really exciting. I just had a call with them today, actually, and working with various trusts across the UK as well, and have our Beacon site, which is University Hospital Sussex. So, and loads more exciting stuff happening, and picked up some awards along the way, which is always lovely as well. So yeah, masses in the pipeline, but it's been a really busy nearly 2 years, and part of what I've done, which has been really helpful, is go on accelerator programs to learn about being a clinical entrepreneur, essentially. So I've done the Hill to start with, which was run out of Oxford University Hospitals, and I'm now on the NHS Clinical Entrepreneur Programme, which has been brilliant as well. So whistle-stop tour of the last 2 years of my life. But yeah, it's been very much focused on reducing health inequalities.
Yeah, and I think that's where it comes from, doesn't it, Rachel? Is it? I mean, sometimes with the simplest idea, sometimes the simplest idea are the most effective. And I think where you find these that are based on a core value, that is the principles there. It's clearly there trying to do something for colleagues or for patients as well. And you got the core purpose is really clear. It's a simple message there to get across, which is why I think it's highly effective and people get it. You don't need to demystify what the product is in the first place. And I think it's just there for colleagues and for patients. Gordon.
Yeah, Rachel, I was going to ask about the ability to change language within CardMedic, because it seemed to me that I was able to, maybe I was going to ask the patient what medications they're taking, and the patient was Polish. We have quite a lot of Polish people in Oban. So I could go down and find the questions in English and then change language to Polish so that they could read the question in Polish and answer the question, then answer presumably back in some way or other. Is that a feature that people are using quite a lot?
Yeah, absolutely. So we've just got this really exciting update, which has got for example, if you change it to Polish, like you said, then you've got the Polish on top and the English underneath. Hello?
Right. Yeah.
Oh, sorry. I thought you just appeared. Yeah, the Polish on top and the English underneath, so you can see exactly what the patient is reading, and that we primarily try and use yes or no questions for that reason, so to allow for that two-way communication. So yeah, I'll do a screen share of the website with you at the end, so you can see it. But yes, allows for that two-way communication. Definitely, that's really important.
Because I thought there were some areas that people think of as very difficult to have the conversations, like do not attempt cardiopulmonary resuscitation, DNA CPR, and it seemed to me that the script there was very sensitively put across, and then if you're able to translate it into the person's native language, should in a lot of cases make those conversations much more straightforward, I'd have thought.
Yeah, thank you so much. We worked really hard on that section, actually, and I've worked with an amazing team of physicians and palliative care nurses across the UK on kind of rewording that section. Teams from Brighton, with Charlotte Eade, one of the palliative care nurses, Ruth Parry, Lucy Selman, and then Catherine Mannix as well. And Catherine's actually just recorded those as her reading them aloud. So once we've got the recording through, we're going to humanize those. So anyone listening to that information will be able to hear it as a human reading it to them, which hopefully will make it even more personal in that way, because like you said, that's really, really difficult news to deliver for patients and families. And so we've tried to structure it in such a way that it gives people plenty of time to think in between receiving certain bits of information, and opportunities to ask questions, respect personal wishes. So yeah, thank you so much for picking up on that section.
Well, and the other bit that you mentioned there, as you went through and just said the frequently asked questions, I mean, this is an idea I've had since the end of last millennium, that patients very rarely ask us questions on ward rounds. They might answer our questions and be quite frank, but when you say, right, we've had talked through, is there something you want to know, anything you want to ask, you usually say no. And yet they must be lying there full of these questions, ranging from why did you change my medication to am I going to die? And Michael Wise wrote a book called On the Toss of a Coin, about when a dental surgeon, when he had septicemia and he nearly going to die from septicemia, and all the questions he had, he wanted to ask people. So between Michael and myself, we put together a whole lot of questions, and I've always said it was going to be like a Chinese takeaway menu. Doctor, can I ask question 101? Are you going to amputate my leg today? So, of course, the CardMedic initially was us clinicians and professionals asking the patients questions, but what Rachel's doing now is putting these questions into it so patients can ask us questions. It'll be really interesting to see how that goes. I suspect that they'll probably use it much more with nursing staff than with doctors, but who knows?
Yeah, we've
fascinating to see what happens.
Yeah, thank you so much for sharing those with us, because they're supposed to be going live today. So I will, as soon as they are, I'll send you the link. But the idea is that that patients are empowered to ask questions back to us as well, and that it encourages us to answer them in a really simple, understandable way that's free of jargon. And one of the things that Nick and I spoke about before with 4 key questions as well that NHS Improvement want patients to be able to ask healthcare staff looking after them, kind of ranging from what's happening to me today to when can I go home. And what we're doing at one of the hospitals that we're doing a quality improvement project using Cardmedic is adding in those key questions when we're talking to patients on a frailty ward using Cardmedic. So we ask them those 4 key questions using Cardmedic. And that will hopefully highlight that not only that a Cardmedic is helpful, but also those other areas that, patients don't really understand what's happening to them or haven't been given the opportunity to ask questions. And it's not because people don't want to give them that opportunity. Everyone's just so busy. And so you would love to be able to pause and explain things to patients, but it's on a busy ward round or, with your bleep going off or there's a mountain of jobs to do. It is difficult to build that time in the day. It's not impossible, but it is challenging. And so I think it's just giving everyone a moment to kind of pause and try and find opportunities to explore patients' thoughts and concerns. And patients could also download Cardmedic as well. So then they've got that access to the FAQs and they can have a read through it. And the next time someone comes to look after them or examine them or do a ward round, they can already have armed with those questions. This is what I'd like to ask the staff.
And I think that's the point. I think this is not because people aren't caring, is it? This is it's just, but it's often so busy. We find ourselves in a situation where we're not wanting to do this, but we find ourselves in a situation where the world that we exist in means that that these kind of tools are helpful to add to that. And it's not that we're not wanting to have those chats, but it's so difficult at the moment. But I think one of the things that I'm not sure if it's live yet or if it was in beta version, but the British Sign Language facility as well on Cardmedic I thought was particularly interesting because again that's something we don't always think about and about how we can add that in. But listen guys, I appreciate your time this afternoon. I'm conscious that we've probably gone on longer than I said we would do. I said 10 minutes, but it's been fascinating to listen to you guys again. It's a really interesting tool, but based on a really interesting subject. And I think, as I said before, it's the going back to that patient I described in the story before. It's just there's elements of communication, how we can communicate well with people. And to Gordon's point about, do we know what's happening? Do I know? If I'm in hospital, do I know what's happening with me? I'm not passive in this. I'm an active participant in my care, and I want to be involved in that. But am I always able to? Whether it's because of restrictions through PPE or difficulty with isolation or just different languages. I think these are the things that get in the way of good communication. And something like Cardmedic, for me, is just a really simple tool that aids there. So I want to thank you for your time this afternoon, guys. Really appreciate it. What I'll do, I'll put the link to Cardmedic and contact details in the text on the bottom of the video here on YouTube, so people can sort of get in touch if they want to and go and have a little browse around the website if they want to. But any questions to either Gordon or to Rachel, please feel free to get in touch. They're always very welcome to have a conversation with them. For now, though, guys, thanks a lot for your time. Appreciate it. Everybody else, look out for the next podcast, which will be coming in a few weeks' time.